p.m. We're going to go ahead and get started. I'd like to welcome everybody to the regular monthly meeting of the Indian River County Hospital District. And we will start with a invocation from Tracy.
Good afternoon, everyone. If you all would just bow your heads and join me in prayer. Lord, as we gather today at this meeting, we ask that you will be in our midst. Help us to make decisions that will be pleasing to you. Help us to be able to discuss the matters at hand in a reasonable way, and may your will be done. God, let this meeting be productive, and as should be the case in all areas of our lives, help us to keep you at the forefront of our minds as we do the work set before us. Thank you, God, for the time we have today to discuss issues and make decisions. Let the work done here tonight come to fruition, and let it all be for your glory. Help us each to do our parts to bring the plans discussed to life. And Lord, we want to give honor to you. May you bless each person who took the time to gather here today, and let your hand of protection be on them throughout the rest of the week. Amen.
Thank you, Tracy. Appreciate that. Michael?
Yes.
Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you.
Thank you. We will start I'd like to hear a motion for approval of the consent agenda for the approval of the chairman's meeting minutes dated April 25th, the regular monthly meeting minutes dated April 25th, and a May disbursement of $972,060.17.
So moved.
Second.
All right, any discussion? All in favor?
Aye.
Okay. Just a couple things. I mean, we've been busy, and I think everybody knows that we continue work on the discussion about the Gifford Health Clinic, and we will continue that discussion. We have several meetings scheduled for next week, at which time we will continue the discussion on what is the best thing to do for the Gifford community there. Speaking of which, I would like to congratulate GYAC on their expansion, and Freddie Wolflick, who's here tonight with us tonight, to say congratulations on a job well done with that. That's a lot of that is because of you, Freddie, so congratulations on that. Okay, and on to the district council report. Jennifer?
Thank you. Just to follow up on what you've said, a lot of the work I've done this past month has been centered around the Gifford Health Center clinic that we're looking to get in place, and that RFP process. Additionally, a lot of work I've been doing has had to do with the upcoming budget cycle and the meetings that we're having on those agencies that are seeking funding for this coming cycle. And also, I've responded to questions from each of the trustees as they've arisen over the past month, and will continue to do so. Does anyone have any questions I can answer? Okay, thank you.
Not at this time. Okay, we'll move on to the financial statement. Mr. Jones is not with us tonight. I believe he has a graduation for a grandchild. So, Anne Marie, would you like to read the statement?
I will do my best. Alan has submitted his report in writing, so I have that here for you. But as is typically the case, the district is in a sound financial condition. At the end of April, the bank account has a little over $9.3 million. Between now and the end of the fiscal year, we expect to receive about $600,000 more. After taking away the $972,000 that we've spent tonight, will remain about $9 million in that account, a little less than that. On the expense side, the projected budget expense of $6.2 million. Estimated actual expenses will total about $1 million less for programs, mostly because the funds for the hospital, now Cleveland Clinic, will not be completely expended and or not be needed. And then we have administrative expenses that'll come in just about at budget this year, and the other expenses are likely to come in a little under $500,000, less than $500,000, mostly because the contingent indigent care reserve and the partnership process reserve will not be completely expended as we had planned. So as a result of all of that, the projected bank account will be a little over $3 million in excess of what our plan was for the year. We'll carry that over as we typically do and should be able to help us reduce next year's next year's millage rate slightly, just because we'll use those expenses. Now, we have had an excess, just FYI, coming up, a little bit of excess request than we have over the year. Over last year, I haven't totaled that completely, but I think it's roughly $1 million or so more than last year. Yeah, a little over $1 million over last year. So, but even with that, some of that will be offset by that extra, so we should be in good shape.
Okay.
Any
Just
other
as a
questions?
reminder, last year when we budgeted, we were not in a position yet where we knew what was going to happen with the hospital. We did not have an agreement with Cleveland Clinic at that point, and so we budgeted at what the hospital had been running rather than anything lower than that. And so because of we are paying Cleveland Clinic at a rate much lower than what the hospital was running for indigent care, if that makes sense, we will have an excess because of that. But that was something we went into hoping that we would have an excess, I think, based on coming to an agreement. But we didn't want to assume we would have an agreement until we had it. So that's why we have the excess. So. And we do have, I believe, Jenny, how many new people requesting funds this year? 11 new agencies requesting money from us this year. So it's going to be an interesting year to go through the budget as well. So I think that's good news in many ways, that the community is coming to us for help. Okay, moving on, the Executive Director report. Anne Marie.
That's me again. My written report is in your package for your perusal. One of the things new, as I promised last month, that is, if you will notice that behind my report, is our new dashboard for the strategic plan. So I have included, this time I think it's in color, and so it is color-coded for you. Good job, Kate. To notice that obviously I have put in red those items that we are maybe a little behind what we actually, our due date was, so maybe a month or so after that. All of the green obviously are those that we have finished on time or ahead of time. And we just approved the governance package, or you all just approved the governance package yesterday. So those items are now completed, and we are working through the education agenda and the learning agenda. So next month I will have that for you to approve and look at for the remainder of the year. And then I will continue to update this and talk about this dashboard each month so that you can see how we're working through or that we're accomplishing the goals of the strategic plan. So any questions about that or any comments that you like or dislike
Just
about?
for the anybody watching and anybody in the audience as well, as part of the education piece we had at the chairman's meeting yesterday, Jason Brown came and spoke to us from the county commissioner's office to understand what it is that they do and what they fund and all of that type of thing, which we haven't in the past always known what other government entities in the community are doing. And so we're trying to learn what they're doing, what they're funding, what they're involved with, so that we understand where we overlap and what we're doing together, and maybe we can be more efficient in what we do in the county. So it's a beginning.
Yes.
It's a beginning.
I
So
think it'll be
good
great
start.
partnerships.
All right, any comments for Anne Marie?
Nope.
Nope, okay, we will, moving right along, we will move into our funded agencies report. So the first is Healthy Start. been a while. Welcome.
Welcome. Thank you so
We
much.
were a little busy this last weekend.
Yes.
It's been quite a couple of weeks for a Healthy Start. Wonderful stuff going on. So it's always a pleasure to stand in front of you all and report about Healthy Start. My part is a small part because I have all these wonderful people with me to tell you about the programs, but I'm going to tell you general about Healthy Start, which a lot of you know, but some of you at home and in the audience might not, so just in case. Healthy Start was created 27 years ago by the state of Florida when the state of Florida had to realize that they had a pretty bad issue with infant mortality. And as they tried to look into the causations, they noticed that each community had its own set of causations and strengths. So rather than trying to solve the issue with a blanket law or program, they decided to empower the local communities to do that themselves. So in Indian River County, we're lucky enough to have our own Healthy Start Coalition, and it is our job to assess what's going on with maternal-child health and improve that, reduce barriers, and ensure that every mom, every baby, every family gets a healthy start. We do that through several things. Some of that is by partnering with wonderful people like you all, acknowledging things that are going wrong in our system and trying to fix them, and then also programs that we house. We have 6 programs that we have under our umbrella, all of which serve a different purpose. So while I'm up here, I'm going to give you a quick update on our coordinated intake and referral program, which we started, I mentioned a little bit last year, and you can see this colorful chart that's in your handout. That's kind of like our flow chart of how families come into our care and go through our coordinated intake and referral process. But the next table is a little bit more enlightening probably for you all. It's an Excel spreadsheet with all of our programs, and then it says the focus of each program. So if a mom comes into Partners in Women's Health, we have Stacy, who is our connection specialist there. She screens with our infant or prenatal risk screening tool, and it indicates that she has indicators for poor birth outcomes. So Stacy will meet with her right away on site and talk with her about what's going on with her life, and if she is open to the idea of partnering with Healthy Start and getting some help, we go through what program would be best for her. And then also the best part of this program is it empowers that mom to be able to make that choice based on her lifestyle, based upon what she needs, based upon what she thinks is her biggest need. So in order, our doula services are for moms that might already know they don't have someone to be with them during their birth of their child. So they are a single mom. Maybe she's a migrant worker, or maybe her husband is deployed. Maybe she is a teen mom and knows that her parents will not be there to support her, and the father of the baby will not be there as well. So we start to meet with that mommy, make sure she has someone to be with her and hold her hand and empower her during her birth experience. Nurse-family partnership, which we're going to report on today, that is for our highest risk moms. So those are the moms that have chronic health conditions, and they really need that extra helping hand. So this provides them with a personal nurse for their family, who's here tonight, Cheryl. We'll talk with you in a minute. Healthy Families is there for abuse prevention. So if that mommy had abuse in her past or indicators for possible abuse, they help that family to break that cycle. Healthy Start services are wraparound services, and that program is more of a health literacy-based program that works with that mom prenatally to prepare her and empower her, get her whatever she needs, smoking cessation. If she's in an abusive relationship, try to navigate her through that, anything that she might need. Babies and Beyond, that's our program for every mom, which also includes our nurse home visitation program, which Kristen is going to be talking with you about in a minute. But everyone has access to that program. And then finally, our Parents as Teachers program, which is really there to provide kindergarten readiness, to prepare that baby to be ready when that first day of school, to be ready to learn. And what I love about this program, it's really for the parents. Actually, the staff is called parent educators, because they're there to teach the parents how to teach their babies, how to bond with their babies, how to create learning experiences with not a lot of money, but with a lot of attention. So with that, I'm going to pass it to actually Elizabeth Bublitz, who is our brand new Associate Executive Director, and she's going to go over some data with you all. She has a master's in public health and actually hails from the west coast of Florida, so we're happy to have her.
Awesome.
Good evening, everyone. Thank you for the introduction, Andrea. So I'm going to quickly just go over some few Florida indicators that we report on. In your packet, you will find that we have represented some information from Florida charts. And one of the things that we would like to point out is infant mortality rates here for Indian River County and also compared to the state's average. The state currently yields at 6.1 per 1,000, and Indian River County is currently at 7.4. However, I do want to highlight a great success within our county, and that is within 2017, it was reported that we had 0 Black infant deaths within our county. So that is a current trend that we hope to see moving forward, especially with our 2018 and 2019 data coming out. The next indicator I would like to point out is late or no prenatal care, and feel free to look at this at your reference. We're currently at 6.6% for 2018 provisional data, and hopefully with the implementation of the PEPW program, we'll hope to see this decrease, as well as our numbers for mothers' entry into first trimester for prenatal care increase. And then lastly, I wanted to just point out for our Healthy Start performance measures that are listed at the bottom. For Indian River County, we are higher than the state average for both prenatal screening rate and women consenting to prenatal screens, and just slightly below the average for the state's average at 86% compared to 89%. So feel free to let us know if you have any questions, and we'll be more than happy to report on any information provided. Yes?
Yes, have you been working on the infant mortality among the white residents of the county? Because it's quite high as compared to the state average.
That's a wonderful question. Thank you.
So, yes, we work with all populations and try to concentrate on everyone. The reason why we point out and celebrate the success of having 0 infant mortalities in the Black community is because in just a few years ago, we were higher. We had a 5 times the rate of average for our Black infant death. And so to go from 26 per 1,000, which Kelly McChrystal compared that to Nigeria rates, to go from that to 0 is huge. But we hope that trend continues. But yes, in comparison to 0, the white infant mortality does seem very high. And of course, we're always addressing everything we can do to decrease those rates. Big part of that is getting into prenatal care as soon as possible, which is why Elizabeth pointed out the early entry to prenatal care and why we're working on getting that PEPW and helping those moms to connect and eliminating that barrier of having to go all over the county before they get to their first prenatal visit.
Do you know what the 2018 rate was?
So it's not verified yet. I could get that to you. So they're always a year behind in their data
We
verification.
have to know. I mean, we know how many babies are born in Indian River County, right?
Are you asking how many entered into prenatal care early in 2018?
No, I mean infant mortality, from an infant mortality. I mean, it would seem like there's not a huge
So I
number,
can-
so we should know if a baby died.
Yes, and we do. I just don't usually report unless it's verified because of public health concerns. But I could probably send you non-verified data. Is that okay with you?
Yes,
I can
we
send it.
understand. I understand, but it just seems like we do know that, right?
Yes.
Okay.
Yeah.
So in women consenting to participate and being lower than the state average, do you have any reasons why?
So so in our county, we are embedded in Partners in Women's Health. So usually what happens is that, right now what happens is Stacy sits with every woman that fills out a prenatal risk screen, and there is two places. I know this is going to get a little technical and weird, but what that spot really means is you sign the consent form in the right places, is what that really means. Consent to Healthy Start services. So if they didn't sign it and we weren't there for some reason, or we missed that mommy, or they were at Dr. Presley's office and we didn't connect with them right away, that's where that number comes from. So that's another reason for the PPW process expansion. If we did get that, I would add another staff member. And so we would have 2 staff members trained on coordinated intake and referral and trained on PEPW. So they would be sitting with that mom, reviewing the screens and saying, if you are interested in these services, you'll need to sign here. Because that's what that really means, is consenting, meaning signing that form.
Gotcha.
And I'll send you the form too, just so you see where it is.
Oh, that's great. Thanks.
Anything else? If not, we'll pass to Kristen, who's going to give you guys an update on the nurse visitation program.
Good evening. So I think if y'all flip back one page, there's some outcome data for the nurse home visitation program. Just a few of the highlights. We are currently, for the fiscal year, we're at 307 visits that have been completed so far this year. The reason we have total fiscal year, ours is a little different. We start in July, so since July, we've actually done 434. I think what's more important to consider is last year almost 2 years ago, when we started this program in 2017, we were only averaging about 45 to 50% of the births we're accepting a nurse home visit. And now we're up to almost 60. Some months we've even had 70+% that the visits are being more accepted. It's become more just commonplace. People are more excited about it. It's been still about half and half that are receiving the visit are Medicaid or indigent versus private. It's about 50-50. But whether you're Medicaid, whether you're private insurance, all of these mamas need help. And so that's what's been so great about this program, is it allows us to offer it, and you guys allow us to offer it to all mamas. And because of that, the program is growing. We are still seeing a lot of thanks and praise that we receive for the nurse home visitation, not to mention just the support, education, and the positive feedback is only one piece of it, because it provides us an opportunity for an assessment like no other. This mom, after just giving birth, when she's at home, it affords her an opportunity to ask questions in the comfort of her home. It also gives us an opportunity not just for a wellness assessment, but a safety assessment. I could go on and on with stories and little things where we have made a difference, from barriers to getting into their pediatrician. When they left the hospital, they thought it was okay and that the Medicaid was the wrong plan or their insurance wasn't working. Then they couldn't get into a pediatrician, and those kind of things that are really overwhelming for a new mom. With that being said, there was even a mother who had an abnormal infant screening, which is a newborn screening that we do on all new babies. She had gotten a call from the state of Florida saying, you've got an abnormal test. So when I walked into the home for the home visit, I was blessed to do it that day. And when I said, hey, how are you doing? She went to tears because she had just gotten that phone call from the state saying, my test is abnormal. We had to go in last night. The baby's thyroid is having problems. And it was, spiraled from there. And then, long story short, the baby was put on medication. She was supposed to follow up with the pediatrician, and her plan was no longer accepted. And, it was just one thing after another, not to mention just the stress and anxiety of having a newborn, and then to add all this on top of it. So it's been a blessing that we've been there in, countless situations similar to those, whether it be blood pressure issues, breastfeeding issues, I could go on and on. But I welcome if you guys have any questions.
I have a question.
Yes, ma'am.
The people that have birthed a child receive a visit. post-birth.
Yes, ma'am.
Do we ever make or you all ever make visits prior to the birthing process to see if the home is safe and what they are providing for the baby
Ahead of time.
is appropriate? Do we have that kind of
Not, that is.
free? Is it something that Healthy Start, does do somewhere? And is it appropriate? Because going in and saying, oh my goodness, you have
Right.
this isn't healthy, or this isn't right, or your baby could, you know what I'm saying?
Well, and the Healthy Start services, the Healthy Start education services, when you're screened in through the coordinated intake and referral, if you are open to letting someone come out, if there are any risk identified for that mama, whether it be age or a previous loss or, it's her first baby, that's considered a risk factor.
How many people accept a visit prior to? Or do you just do it at a location and,
all of those that are enrolled in our programs. So, let's see, of the moms that are so we have 1,200 births per year. We usually have about 400 enrolled in our services.
right?
And so that means that many women will receive some kind of visit. And usually, so we try to, beforehand, yeah.
Oh,
Through their
okay.
pregnancy, so throughout their whole pregnancy. And then some of them, we have to work up to the trust level of moving into their home because we try to meet them where they are. If they're not comfortable, then we'll meet them at their prenatal visits and do everything we can. But the idea is always to end up in the home because your heart opens more when you're in your home, but also we want to be able to look at what's going on in the
Sure.
home and see
That's
what's
a
happening.
preventative type of thing.
And all of our programs, I don't remember if Andrea said that, all of our programs are home visit based.
Yeah.
So it does, depending on what program the mom might be interested in, it does afford us, several different opportunities to go into the home, not just postpartum. But the nurse home visit was designed specifically
Right,
as kind of an extension of your hospital care.
right. So postpartum visit.
Right,
at least
so
one.
for
Right,
those moms, we typically go see them within the first
yeah.
3 days to a couple weeks, because sometimes they get rescheduled.
Right.
So
Oh,
it
thank you.
it provides.
So the average of about a third that sign up for Healthy Start, is that,
Only a third, yeah.
is that a choice or a constraint because you don't have the capacity, or is that,
For the nurse home visit, I'm sorry, I didn't
yes,
understood the
Yeah.
400 in service versus the 1,200 over the year.
Yeah.
right.
Is that what you're saying?
Yeah, is that a constraint in your
Well, and-
capacity, or is that because they choose not to be
That
part
is-
of it?
Right, they have chosen not to, and that's this fiscal year.
Right,
So,
right.
I'm figuring, based on that, we'll make 600,
Right,
a little over 600 visits for the total fiscal year, but again, that's only half of all deliveries-ish,
But it is growing
yes.
with the program.
So yeah, that's what, last year, or 17-18, we were at about 45% of moms accepting the visit. And now we're closer to averaging 59 to 60% are accepting.
That's good.
So it's improving.
Right.
I want to mention too that we base this program on a program that already operates in St. Lucie and Martin County. And their program is, we went to go visit them, and Kristen spent a lot of time with them when we were setting up this program. And they've been doing it for 20 years. And their acceptance rate's almost 100%. Because it's integrated into what's going on. It's just part of your care, and everyone expects that you're going to get that
So it's a
visit.
growth and everyone getting used to it and
Exactly.
trusting it and knowing it's there.
Right.
Yeah.
And not feeling threatened by it,
Exactly,
for someone to come into their home.
right.
You know,
You're not judging,
Right.
you're helping. You're there to assist and help.
exactly, we're
save
not there for a
baby.
home
Sure.
inspection.
Right.
Yeah,
Thank you.
absolutely. Anything else? Thank you, guys. Sorry, I could introduce Natasha and Cheryl for the Nurse Family Partnership. I'm sorry about that.
That's okay. Hi, glad to be with you. I'm Natasha. I'll just start a little bit about explaining what Nurse Family Partnership is. I don't know if anyone is pretty aware of the program, but it is an evidence-based program that is based out of Colorado, and it's working a nurse actually going into the home, doing home visits, working with a first-time mom, low income, providing education, developmental guidance for when baby's born, giving mom that extra support during her pregnancy, making sure for that positive birth outcomes. Also connecting mom with community services, deemed on what is needed based on working with the mom. So that's basically Nurse Family Partnership, and Cheryl can always chime in. She's the nurse that's really working really hard with our clients out there, sweating and so I'll go over the highlights if you want us to sort of go more into Nurse Family Partnership of anything I didn't cover, please let me know. But Nurse Family Partnership really started at the end of, really should say beginning of October. And at that moment, we only had 5 clients, and we were really targeting, I believe, the Gifford area and then certain zip codes, like teens in certain zip codes. We did change that criteria mid-January, so we went from 5 clients to enrolling 15 new referrals between January and to present. And our conversion rate in terms of the amount of referrals that we have received from the CINR system through actually enrolling clients has been 54%, which is higher than the state level of 39.5%. So Cheryl has really been working hard in trying to get these clients enrolled. Currently we have 17 clients. We lose some here and there. That's, it's that with clients that move away or that just disengage from the program. But we have 17 clients, three of those clients delivered, 2 full-term, 1 baby born at 36 weeks with a birth weight of 6 pounds, 7 ounces, no NICU admission. So I don't think that's one that she will sort of delve more into. I don't think if Cheryl wasn't involved with that mom, she would have made it that far. Even though we wanted her to make it further, but that's okay, we took it. And out of the 3 NFP mothers, 2 out of the 3 initiated breastfeeding, so that's something that we're working with in terms of increasing that number. We're still small, but we're hoping that number will get higher.
Do clients pay for any of this? This is all free to them.
It is
right?
free. It's a free, and that's how we sort of push it out there. You get your own free nurse. It is a free program. It is to our low income.
I'll take it.
You'll take it, I know.
You don't qualify.
I think it's a positive. I think that's usually, once they hear that, oh, I get my own nurse and she's free, and they that's how she gets in. So
She comes to you and tells you she's pregnant, you better get hold of all of us.
Yeah, I know.
Put me away.
Anything else that we missed? Or any other questions? Okay. Cheryl will go more into pretty much, I guess, working with the clients.
Good evening, and I'm Cheryl Martinez, the nurse with the program. And this has been a very exciting experience, just being able to get out in the community and to build that trust. That's one of the things, just to build a trust, because they are home visit programs. So it really requires that trust for them to make that commitment, because the program starts when you're less than 28 weeks pregnant, and we follow you from every week to every 2 weeks, all the way up until the baby turns 2 years old. So it's definitely a commitment that the moms do make, and we are able to provide that support before they have the babies. And as you asked, I'm able to get into the homes and to kind of see what type of resources that may be needed, or just kind of refer out. So we definitely do a lot of referrals out in the community to make sure that they are self-sufficient and able to find everything that they need. We do deal with a lot of the high-risk moms, because they're first-time moms, so they have a lot of questions, and they're already high-risk, and also at a socioeconomic disadvantage, because most of them are low income, because that's one of the requirements of the program, that we help assist with those clients. We had a particular client that she had a lot of chronic illnesses that she was dealing with amongst her socioeconomic issues, that we were able to step in and able to provide her with those resources and supports that did get her all the way up to 36 weeks, and the baby went home with her, did not require any NICU assistance. She breastfed the baby, and definitely that is a success. And currently she's still enrolled into the program, and I'm able to assist her and to follow her all the way up until the baby turns 2. That was just a way that the community, because along the way through that process, she had some issues with her apartment, with her AC, so we were able to kind of address all of those issues and just to support her and to have a healthy delivery with the baby, and how the community really steps in together and work together, you know, with the resources to help the moms be self-sufficient and just to change the health literacy, you know, of the community, and to avoid that NICU was really, you know, a positive thing that we work on and really provide that support to the moms and the families.
Could you mention something about the pediatric care following birth? Where are they mostly referred to, or how does that work so that they're followed immediately with a pediatrician or a nurse practitioner, a pediatric nurse practitioner?
Usually when they leave the hospitals, they make sure that they already have their follow-up appointment with the pediatrics, and we do follow like in the program to make sure that they are already and have a pediatrician that they've chosen.
And how many are available to the low-income, perhaps, population? Where do you refer?
Yeah, we have some at Whole Family. They see them there. Also at TCCH.
Right.
We also have adolescents. Dr. Ouija Telecki.
Yes, sure, Dr. Ouija. Mm-hmm.
Just depending on the type of insurance they have,
Right.
I can give them a whole list of the pediatricians that will accept their insurance.
But every child does have a pediatric, someone that will follow
Yes.
and continue to follow.
Right. And we make sure, you know, along those points that they're having their well
baby visits.
Yeah, their well baby visits.
Right. But you follow them up to 2 years.
Yes, ma'am.
So we don't know what happens after that, but up to 2 years, because
Right.
you're Healthy Start.
Exactly. 'Cause
Somebody has to be Healthy Finish, continuation or something.
We're definitely there with them. A lot of the crucial times that brain
But healthy in between, too.
In between, right? Never finishes, but nevertheless.
Right.
Okay.
But we are there through a lot of that important brain development, you know, with the baby. So we're there at those very crucial times.
And of course, you working with them, you're hoping that this will allow them to continue that process.
Right.
Whatever you have taught them and educated them, they will continue and follow through with that. So you're sort of, we say we're sort of building communities. So
Does a Healthy Start finish at 2 years, or does it go, or does,
Healthy Start can go, I believe it's up to 3 if needed.
really?
There are other programs in our community that kind of start at age 3 also that Healthy Start collaborates and refers to as well.
But at age 3, but we go to 2, so you wonder, you know, if that needs to be expanded.
That's just this particular program,
I
though.
know.
Healthy Start in general goes all the way to 3 years old.
Yeah.
Definitely.
Oh, good, okay, great, okay.
They work together.
Good.
Thank you.
Thank you so much
Thank
for
you.
all the good you do in the community. Appreciate it.
Andrea, do you want to speak about your event this weekend and how exciting it was?
I'll speak a second about it. It's really exciting. We had our 11th annual Dancing with Vera Stars. And so our 10th annual, which Tracy danced, you guys know she danced for us in the 10th, and that was our biggest
Yes,
year.
we knew that.
Did you know that?
Yeah, we
She
need
took
that.
something home with her that night. There's not much she didn't take home that night, to be honest with you. She won like every award there was. last year we raised 350 and we thought that that was a lark and we'd never be able to do that again. And this year we raised $500,000.
Wow, that's
Wow.
awesome.
Yeah.
Good for
Wow.
you. That's awesome.
A lot of work. We did it, and we're going to try to listen to you guys when you tell us to rotate that into some deeper philanthropy. And so that's our next step that we're making. So thank you guys so much.
Congratulations on your state position, too. Yeah.
Yeah.
Yes. Yes. Okay. Thank you very much. Next, we have New Horizons. Hello.
Good evening. My name is George Shoplin. I'm President and CEO of New Horizons. And this is my first presentation, so I want to thank all of you for the ongoing support that you show New Horizons and our mission to help the community. I've been CEO for 5 months. And
Okay.
many of you
We'll go
are
easy.
many of you are very aware of New Horizons and their mission and what they've done. New Horizons is the most comprehensive mental health provider in the Treasure Coast. We've been here helping our communities for the last 60 years. And in that time, each year we help tens of thousands of people through one of the most comprehensive array of services that are out there. As CEO, to take kind of a small sidebar, I was blown away by the quality of programs and the array of programs that New Horizons has. I am blessed to have a staff that are humble and dedicated and passionate. And those are 3 things a CEO would want to walk into. So John Romano, my predecessor, has built one heck of an organization. And I feel very fortunate to be walking into that. What this also has done is provide us an opportunity really to introspect as an organization of this strength and look at really what we are able to do and strategically how we can continue to help the communities. What we have done is engage each of the counties and began discussing what are the needs within those county services, and including Indian River. And those conversations are really looking at, as New Horizons is, due to its size and its skill set, how do we best bridge those gaps in care? I don't think we all can agree there are a number of providers in the community, and yet there's still gaps. I tell people I can double a number of my programs in size and they'd be full in a month or 2. And it's a sad reality that we have. I think you've seen through the support you've given New Horizons year to year, those needs continue to increase. What we are looking at currently is how do we increase accessibility to a current array of services that we do provide, because we do have wait lists and things that do sometimes delay care. Well, we're also looking at strategic partnerships with different groups that we can provide care and unique in different ways. And then we're also looking at ways to innovate. I think there may be opportunities there. And then last but not least, we're engaging a lot of the other providers to partner. I think that organizationally, a partnership is one of the things that really creates a strong community. And I think here in Indian River, you guys are actually setting the tone with the collaborative. I think that is something I can tell you doesn't exist in any of the 4 counties but yours. And I worked in 5 other states, and you guys are unique in that. So I applaud you for that, because that is an amazing array of services. And just the grassroots feel and nature of that is very personal. And I think that really lends itself to really how it supports the community. We are currently, some of the issues that we are facing, just to share, is because of the volume of referrals to our outpatient services, and in Indian River as well, one of our offices here, there are some delays. We are right now working with the local hospitals and Brett Hall himself and the collaborative to create some meetings as to how do we increase accessibility. Sadly, the outpatient referral that you guys do fund part of provides opportunity to avoid recidivism and readmission. And I think, and I don't want to sound as a cliche here, but I think most of what we do is you broker in hope. I think most of the work we do is hope-based. People we see are hopeless. People we see have gone through so many failures and so many iterations of the care we provide, that what we really got to focus on is how do we provide care that provides hope? And that's a challenge. So what we attempt to do is really engage people and provide care that gives them the inkling that it can get better, that there can be improvement. And from that, we can avoid that readmission, which then creates that cycle of failure versus that cycle of success we're looking for. So what we're trying to do, and we just discussed a potential pilot program, because what we're finding in our outpatient services is long delays in getting in and care, which would prevent of another recidivism, another failure, another readmission, is looking at having an open drop-in day, an open intake day. Where basically one day a week we just have the doors open and anybody who needed care could come in, as opposed to setting appointments and canceling appointments and rescheduling appointments and coordinating. So at this point, we're trying to figure out the best way to structure that and organize that and fund that so that we can have a day when people can just come and get care. We'd have a psychiatrist or ARP available, along with master level therapist and a support staff, so that people can get care in that moment in time. So the longest length of time they would have without receiving care would be 1 week. And that would be a significant improvement. So we're looking at that as a pilot in one of our 3 outpatient sites, and ideally then generalize it out, the hope being, of course, that we can move quicker to do that. One of the other exciting things we're doing at New Horizons is we operate a children's Baker Act receiving facility, our crisis stabilization unit for children. And at this point, it is mixed population of younger and older children. And I've done this work for about 32 years, and I know that won't provide the best level of care. So we have a small work group working on creating a younger children's crisis stabilization unit, because the admission for a child into one of my facilities is traumatic, and I don't want to soft soap that. I don't want to make that sound, no, it's okay, they're getting help. It's scary. This may be the first time they're away from home, first time they're not sleeping in their own bed, the first time they're not with mom or dad. They're with me. And they're with me with sometimes older adolescents. And that's concerning for me, because we do not want their help in crisis to be traumatizing, and at times it is. So what we're doing internally is looking at how do we create a safe space for these children to be welcomed into care in a way that is warm and receiving to meet their biological developmental need, while providing the care necessary to minimize the negative impact associated. So we're in the process of really looking at that in a very detailed way, and those are some of the exciting things we're looking at doing. Questions for me? Because I could talk about New Horizons for another hour easily.
What age group are you talking when you talk about younger children?
Well, we treat children as young as 5. So we're looking 5 to 11, 12. And I can tell you this was initiated by me coming across a 5-year-old carrying his blanket at cafeteria one day, and I went, we need to fix this. So I initiated that initiative. Other questions for me?
So where do you, I think this is a growing problem in our country, but where do you see that growth happening? In the younger, are you seeing, is it across the board, or?
Yes. No, I think what you're seeing is, if people look at simple statistics, it looks like there's just an ongoing increase, and it's relatively flat, and a lot of the services provision aren't making the impact we hope. I think what we're having is a shift in the problem sets that people are facing. I think there's issues of isolation, issues of depression. The suicide rate is on a dramatic increase, especially a younger population. It's the number 2 killer for those people. Where I think, if you were to ask me that question, where is it growing, I would say where maybe the best impact would be is in that late elementary, early middle school. What we're finding is that there are patterns of behavior being established at that age that's very difficult to undo. When we treat adults, it's not maintenance, but it's really just ongoing support, because there's a chronicity behavior that's been established. At the younger ages, they're pliable, that you can have an impact and truly change their life course. So we're really right now working in the schools and in the homes and those things, trying to get to that population. The issue we have is our society has shifted to a very isolated society. We've moved from the nuclear family, we've moved from the community sense, we've moved from that to my phone, which are these horrible, awful things. Because if any of you have kids, what do they do at dinner? Or what do they do when they're sitting together? What are they doing next to each other when they text each other? They're not looking at each other. I picked my daughter from middle school, and she's like this, next to her friend who she's texting. And I go, did you say bye? No, I texted her, we're good. Okay, get in the car. But it's that disengagement that allows people to feel very isolated.
But you can't treat the children without
Treating the parents.
helping to treat the parents.
That's exactly right. And so what we like to do is the fact that we're in the homes, the fact that we're able to get in there. Now, I'll tell you honestly, the schools are a wonderful place to initiate, because it's a place where the kids go. you can access the children, be able to assess the needs, be able to intervene in a robust, comprehensive way. And then through that, because the parents are more willing to allow you to provide care in schools because they don't have to leave work, they don't have to find transportation, which is an issue. But then we do have to get to the families. But it's interesting. We talk about hope. Parents of a mentally ill child lose a degree of hope. They're not sure it'll ever get better. They feel vulnerable because somehow they might have failed or they're seen as if they failed.
Sure.
So it is about really making an initial impact with a child, which then gives you that credibility and then get to help the family, help mom and dad, mom or dad.
Yeah.
Are some of these children not even with mom and dad?
Many
They're in
are not with.
foster homes and stuff?
Yeah. And the whole, and I can do another 20 minutes on foster care, but foster care as a whole, there's not enough foster families, not enough qualified foster families. And the problem we have in the state of Florida is when they age out of foster care, literally they are dropped off.
Yeah.
There is a gap in care
Right.
as
On
a
the
child ages out of foster care.
Mm.
And what you end up seeing is a significant spike in homelessness in that population because they have nothing. They have no family. The foster family ceases to be there, and then they end up literally.
One agency
Yeah, we
in
have
town.
one
We have
agency
one
that tries to pick up the
Yeah.
18 to 21, you know, and, but there's still not enough,
Oh, no.
not enough.
And the shame is you have with that, and again, I could do this for a long time. This is this is what I'm very passionate about. Is the issue you have with that? Then you also have the risk of human trafficking of those children.
Yeah.
They're vulnerable. They need something. People can easily then meet those immediate life needs, the safety needs. I'll give you a place to stay, and I'll give you something to eat. That opens a door to some very, very, very horrible outcomes.
It's also difficult to relate sometimes to an 18-year-old. They do have minds of their own.
Yeah, they most certainly do.
Right.
And I think we can.
Oh,
we
it takes
stop
a
here.
special talent, I think.
It
Yeah.
does. And the shame is the mind of an 18-year-old who's been emotionally stunted at 10
No question.
is even a much more complex
Yeah.
matrix to try to get through to get messages across.
Yeah. I asked about the home because you can treat as much as you want to treat, but then if you send them into a home that's dysfunctional, and it just almost, it's just repeats itself. So.
It's doomed for failure. I agree with you.
Yeah.
I do. And you also see a multi-generational issue. The parents who were once in care of children who've learned external controls versus internal control. I mean, there's a lot of multi-generational issues with this as well.
The breakdown of family.
Exactly. And I would go back to say we've lost that sense of community that allows you then to get support within your community. We rely on agencies to provide the support, which is a further depersonalization of what they're facing.
Well, you guys do great work in the community, and you guys also do a lot of philanthropy because you only get a certain amount of funding. And I think you guys have an event coming up on Monday at Grand Harbor.
I love the plug. That's fantastic. I didn't even have it on my list to talk about. I thought it was shameless, but thank you for throwing me at that. We are doing a fashion show here in Vero, and it is 4th, 5th annual.
Are you in it?
I was in it last year.
Okay.
It was actually a lot of
our
fun. It's at
mayor
Grand
in it?
Harbor.
Last year was a stellar year.
Yeah,
Thank
apparently I was very busy last year.
It's a wonderful event. Actually, it's 4 local designers that then we have models, local people from the community who.
Any men in it, like perhaps our mayor, Zudans might?
Mayor Zudans is not in it this year.
Oh, okay.
I don't think they have any men
No,
in
there's
it this
not.
year.
It's not. Actually, the conversation actually is next year to do a
Yeah.
Mother's Day mother-daughter for next year. Good news.
That would be nice.
Very, very
That would
cute.
be very nice.
For us, really, the idea behind the fashion show, besides being fundraising, is stigma of mental illness in our community is high. We don't talk about it. It's that secret we don't really want to discuss publicly. And it allows us to make it a little more approachable in those kind of events. We have about 200 people coming. And we have a speaker in the intermission between 2 of it. We have an opportunity to really begin to personalize mental illness. And I think really the only way we can break down some of those barriers is allow people who have enough courage to say, here's what I went through. I'm a successful pillar of our community, and yet I've had these issues.
Right.
And we have people who are getting to that point. We're looking at how do we lower that stigma as well, because that will then allow people who are hesitant to receive services to be courageous enough to come in. People are scared to turn on to my main campus on Midway Road. I hear from everybody. They're worried anybody's going to see their car go in because they're getting help. It's sad.
I would venture to say there's very few people who haven't been touched in some way in their family or whatever, though, with either themselves or their family.
I would completely agree.
And it, yeah, you're right.
Yet it's still a
The
secret we
stigma
don't want to
getting
talk
through
about.
that.
Yeah.
Talking about it. Thank you for what you do.
Thank you,
you. I appreciate
and
it.
welcome.
And welcome.
Thank you very
You
much.
did very well for your first presentation to this
Can I ask
esteemed board.
Well, thank you very much. I appreciate it.
Trustees.
Thank you all again for
Mary,
that.
Thank you.
Mary Beth, can George talk a little bit about, for a minute, about their budget and where we're at this year and where you plan to end up? And
What,
only because I'm seeing, if you look, they are at 52,000 of the 55 that we have, and we still have several months to go in our.
we looked
So
at
if
the
you'll talk
increase, yeah.
just a minute about your volume and what you think you might need by the
We've
end.
seen the increasing ongoing volume has obviously increased year to year. When we really do the projections, we said we're 52,000 to 55 budget at 7 months in. We're forecasting about a $30,000 shortfall
In Indian River County.
in Indian River County
Very
for the clients we serve now. That even factors in a slight slowdown for summer, which is a seasonal effect we see, to really try to get a good realistic number, but we're looking at a shortfall about 30,000, which we would need to request additional funding for.
And you know that you can come back here to request
Yeah.
that additional funding, right?
Yep.
Where are
And
they? Good.
So you need to be on top of that and not be shy.
I've never been accused of being shy. No, but I appreciate that, but it just make you aware of that. And that also then would lead right directly why the next year's budget request is a flat of that amount of 80,000 total.
But do come back as you see, as it's
And
creeping up.
Is that raising the limit from the 150 to 200? Or is that,
No, I don't think they has that yet.
you don't have that yet?
Mm.
Huh?
Yeah, did you notice if you're
Because
requesting?
we changed our requirement.
I would,
It,
I think it is, honestly. I would need to look at it myself. I'd hate to give you false information or inaccurate. I can glance at that and get right back.
so can we talk about that next?
Please make sure that it
Yeah.
accurately reflects what you really believe, plus the increase up to the 200%.
You got it.
Okay,
So
Definitely.
that's in effect.
yes,
Excellent.
okay.
Thank you.
Thank you very much.
Thank you.
so much. Do we have any unfinished business? Any new business? Any other business? I've never really understood all that, but, any public comment? Nope. With
Guess
that,
who's missing?
we'll call for an adjournment. Thank you all for being here. Appreciate it.